Hello friends, this is your surgery ka dost, DRM Dr. Rakesh Mittal. So in this session we'll be discussing a few more questions of the biliary system, gallbladder and bile ducts. Some of it we have already discussed in part 1. So this will be extension of the same session. Okay, starting with the first question. A 56-year-old male healthy physician notices his eyes are yellow. So that means it's jaundice. Okay, first information. Losing weight. So weight loss towards malignancy. On physical examination, jaundice, sclerolictus, benign abdomen means no abdominal findings, no lump, no tenderness, nothing. Ultrasound demonstrates a biliary ductal dilatation without gallstone. Bile duct is dilated. Which of the following is the most appropriate next step in the working up of this patient? See, jaundice, malignancy, CBD dilated. So you can think of what possibilities? CBD stones, but specifically mentioned no gallstones. Okay, and there is no pain in the abdomen. Okay, what else? Bile duct malignancy. Bile duct malignancy 56 is pretty young for bile duct malignancy, and no other risk factor has been specified. Now, here the first possibility I would keep is pancreas. CA pancreas, pancreatic adenocarcinoma. And the investigation of choice for pancreatic cancer is CT scan, contrast CT scan. So that's the answer. ERCP is more useful for chronic pancreatitis, for ductal stones, ductal cancers, where you can take the brush cytology, you can take the biopsy, you can put a stent. But here first we have to make a diagnosis. Okay, later ERCP would be required, but the most appropriate next step. First is we have to make a diagnosis, then secondarily, obviously ERCP would be needed to put a stent in CBD, right? To take care of jaundice. Acute abdominal series, no, not useful. PET will be required at very late stages for staging. PET is usually not for diagnosis, it is mainly for staging. So CT is the investigation of choice. So this is from Billy and Love. Multi-detector CT is the image for lesions in the pancreas. Okay. So won't waste much of time on this. 80-year-old man with the history of symptomatic cholelithiasis. So symptomatic gallstones. Signs and symptoms also. So gallstone with small bowel obstruction. Any question? This probably I discussed in lot of details in the part 1. So won't waste much time here. This is a straightforward case of gallstone ileus. And I told you the air in the biliary tract confirms the diagnosis of the cholecystoenteric fistula, pneumobilia. No coffee ground aspirate, nothing in the stomach, leukocyte count can be high but not diagnostic. Palpable mass, no. So pneumobilia, air in the biliary tree is the diagnostic, right? So this I probably showed you in the, so gallbladder, large stones, there is a fistula, that is most common is cholecystoduodenal fistula. Stone going down, it's getting stuck 2 feet proximal to ileocecal junction, distal ileum, terminal ileum, we have discussed in details, right? So air from the bowel will enter. So pneumobilia is the confirmation for the fistula between the gallbladder and the bowel. Okay, so let's not waste time. 47-year-old asymptomatic, 47 asymptomatic, incidentally found to have 5 millimeter polyp, no stones. Focus. Read the question carefully. Don't miss any vital information, right? If you miss this, suppose there are stones, then the answer will change. So don't just jump on the conclusion looking at polyp, right? See if it is with stones, without stones. Okay, which of the following is the best method? For a simple polyp, small polyp, asymptomatic polyp, without stones, it's just observation with repeated ultrasound. Every 6 months, you can get ultrasound done to monitor the size of the polyp, if it is expanding or not. So, for gallbladder polyps, the indications for surgery. First of all, symptomatic, where symptoms are directly related to the polyp. ऐसा नहीं है कि उसको acidity or you operate for the polyp. No. The real indications are more than 1 centimeter polyp size. So first two are rapid increase in size. First is straightforward, size is big only. Big for polyp is more than 1 centimeter. If it is 1.3 centimeter polyp, you operate. Why? Higher risk of cancer, malignancy. You should know why. More than 1 centimeter, rapid increase in size. That's why serial ultrasound, you have to watch it. And polyps with stones. That's why I focused on that point. And fifth is old age. More than 60 years. Higher risk of malignancy compared to polyp at 20 years, 30 years, 40 years. So everything is important. Age of the patient, size of the polyp, whether it's increasing or stones are present or not. These are the indications you operate. Otherwise, leave it as such. Don't do anything.